लखनऊ में केमिस्ट्री एवं लैब मेडिसिन प्रैक्टिशनर्स का 3 दिवसीय सेमिनार संपन्न हुआ। राजधानी लखनऊ में केमिस्ट एवं लैब मेडिसिन प्रैक्टिशनर्स के लिए आयोजित WERFEN के 3 दिवसीय सेमिनार के तीसरे दिन विशेषज्ञों द्वारा आधुनिक लैब तकनीकों और डायग्नोस्टिक इनोवेशन पर विस्तार से चर्चा की गई। सेमिनार के तीसरे दिन डॉक्टर अभिशांत ने अपना प्रोजेक्ट प्रस्तुत करते हुए लेटेस्ट लैब ऑटोमेशन, क्वालिटी कंट्रोल और एक्यूरेट डायग्नोसिस की महत्ता पर प्रकाश डाला। उन्होंने बताया कि आधुनिक टेक्नोलॉजी के माध्यम से न केवल रिपोर्टिंग की सटीकता बताई जा सकती है, बल्कि मरीजों को समय पर भी विश्वसनीय जांच सुविधा भी उपलब्ध कराई जा सकती है। प्रेजेंटेशन के दौरान प्रतिभागियों ने तकनीकी सवाल पूछे, जिनका विशेषज्ञ स्तर पर समाधान किया गया। सेमिनार में बड़ी संख्या में केमिस्ट्री एवं लैब मेडिसिन प्रैक्टिशनर्स उपस्थित रहे, जिन्होंने इस ज्ञानवर्धक सत्र को उपयोगी और व्यवहारिक बताया।
Namaskar. I would like to thank the organizers of ACC LMP-Con for having provided me this opportunity. I will be talking about a test which is one of the most commonly requested tests in a coagulation laboratory called D-dimer. And this is particularly useful in the setting of VTE, DVT and PE put together. Now I have 20 minutes and I am expected to concise everything and put it as a small package. So this is particularly useful in VTE in a rule-out setting. That is simply because appropriate D-dimer testing has significantly reduced the number of unwanted radiological investigations. Now D-dimer also plays a very important role in diagnosing some of the very important systemic coagulation disorders, most notably the DIC, wherein sequential monitoring helps us. So over the course of next 20 minutes or so, I'll be discussing on the basic physiology of D-dimer formation, the clinical utility of it, more so in a VT setting and also in a cancer setting, the different methods which are available for its routine assessment, and the current problems which both the clinicians and laboratory personnel face. And is there a need of harmonization of these commercial immunoassays which are present in the market today? So just to set the context and explain to you the utility of D-dimer, let me share a case with you of a 52-year-old male who's a sedentary office worker, presenting complaints of shortness of breath with left-sided neuritic chest pain for 1 day. History, well, nothing much significant. Clinical examination, other than reduced breath sounds, there was no calf tenderness, swelling on varicose vein. Investigations, the routine investigations were all well within normal limits. So by all means, we could have put this patient into a low risk or at most a moderate risk PTP, which is your pre-test probability of having VTE. Now, following which a D-dimer test was conducted on this patient, which came out to be 2.1 micrograms per mm. The cutoff is less than 0.5. Now, since the D-dimer was at an elevated level, of course, this had to be confirmed by imaging. CT pulmonary angiography was done, and there was filling defects shown, which conclusively proved acute pulmonary embolism. So the final diagnosis was acute pulmonary embolism confirmed on CTPA, supported by elevated D-dimer. Now, why is this test particularly important in such a scenario? That if at all the D-dimer in this case was below the cutoff level, there was no need of an radiological examination. So this definitely helps us, brings down the number of unwanted testing. So first thing first, what is D-dimer? Now we understand that the clot is actually broken by an enzyme system called the plasmid. And D-dimer is the final product of the plasmid mediated degradation of cross-linked fibrin. Cross-linked fibrin is the insoluble clot or the hard clot. So clot is degraded by fibrin, by plasmin, and plasmin converts fibrinogen initially to fragments X, Y, and once fibrinogen is acted upon by factor 13A, it becomes a soluble clot, and once plasmin acts upon these cross-linked fibrin, we have D-dimers. So let's understand the pathophysiology of fibrinogen also. Now, so basically, it has three components, three very polypeptide chains, A alpha, B beta, and gamma. Of course, with the release of fibrinopeptides A and B, this fibrinogen gets converted to fibrin, which is in the beginning stages, this is a soluble one, which is again acted upon by factor 13, and it becomes an insoluble or a hard clot. Now, once this is acted upon by your plasminogen system, which is your fibrinolytic system, you have D-dimers. So what does one do once you come across, say, a case of high D-dimer? Now, the first priority is, of course, to exclude VTE with clinical assessment and thorough imaging if needed. Now, if negative, then check for conditions like infection, inflammation, or cancer. Also consider physiological factors like age, pregnancy. And if no pathology is found, the patient should be reassured and no unwanted repeat testing is warranted. Something very, very significant with relation to age. We know that age, D-dimer increases with age, and greater proportion of older patients above 50 years of age will have higher than the conventional cutoffs of 500 nanograms per ml. So age-adjusted cutoffs are validated and recommended for diagnostic workup of VTE, especially in patients above 50 years of age. Now, we also understand it has a bearing in females during pregnancy, postpartum, and OCPs. Exercise, of course, again, it's a physiological condition. Strenuous exercise causes fibrinolytic activity, which can potentially lead to raised D-dimer levels. DIC, it's a severe life-threatening condition caused by diffuse and persistent activation of the hemostatic system. And this is, D-dimer is the cornerstone because of its high negative predictive value. Now, where all does D-dimer figure out in terms of its clinical application? So, the top 5, which is your, in cases of low clinical probability VTEs, in cases of recurrent thrombosis, in cases of DIC, in cases of ACS or acute aortic dissection or severe infection and sepsis. The rest, other indications are there, but these are not validated and not substantiated. Okay, so the role of D-dimer in CVD. It has, of course, it has a diagnostic role. Thanks to its excellent NPV, D-dimer is widely used to rule out DVT and pulmonary embolism. It has high sensitivity but low specificity. So elevated levels can also be seen in inflammation, infection, trauma and malignancies. ACS, thrombus formation and breakdown. Why a D-dimer assay in VTE? Why is it so significant? The clinical utility of D-dimer assay in cases of low or moderate PTP, pretest probability, a negative D-dimer almost always excludes the presence of DVT or PE. And in fact, 90% of the patients sent for USG are negative. Significant cost savings and reduced radiation exposure. The power of NPV, a positive D-dimer does not confirm the presence of DVT or PE. That was the reason why in the case which we saw at the beginning of the session, that despite the patient having an elevated D-dimer levels, we had to substantiate and we had to confirm it using an angiography. So the power of D-dimer lies in its NPV, which is your negative predictive value, the ability to exclude the presence of DVT and PE when used along with a PTPS score. So this is the algorithm for diagnosis of DVT or PE using D-dimer. You of course, you begin with, you need to do a good PTP examination. So the clinician becomes very, very important here. Clinical PTP, if it's low and intermediate, proceed with D-dimer. If it's high, straight away you can take the patient for radiological examination. If normal, again you can safely rule out. If it is elevated, you will have to subsequently take the patient for a radiological examination. So it helps in clinical decision making in patients, again I would reiterate, in only and only in low and medium PTPs. It has high sensitivity, low specificity, and is used to rule out and not in rule in settings. Now, I mentioned this word called PTP. So what is PTP? There's a well score for DVT and PT, and you have specific cutoffs. Like in cases of DVT, if it's more than 2, you have a high probability of the patient having VTE. In cases of less than 1, it's low probability, and 1 to 2 is intermediate probability. Likewise for PE, your pulmonary embolism, more than 6 is your high probability, less than 2 is your low probability. Okay, apart from the diagnostic roles, it also aids in prognosis with increased risk of future cardiovascular events, MI, stroke, VTE, helps in also suggests ongoing hypercoagulability and higher mortality risk. Okay, monitoring role in patients on warfarin or on DOACs, it can help and monitor the thrombotic activity and also used after coronary interventions or surgeries. Okay, now let's look at the role of D-dimer in cancer. So we know that D-dimer plays an important role in diagnostic, prognostic and monitoring role in patients of cancer because of its association between malignancy, hypercoagulability and fibrinolytic activity. Now we know that coronary cancer associated thrombosis involves the activation of coagulation, dysregulation of fibrinolytic system, inflammation and cytokine production. So you have a malignant cell, you have the cytokines, you have interleukins, there is tissue factor which is getting released. So all of this culminates into formation of fibrin and of course subsequently a thrombosis. But what is to be noted here is that the most common type of cancer associated thrombosis yet again is VTE, which is at a 9-fold increased risk in cancer patients compared to the general population. Not just this, it is also estimated that 20 to 30% of all VTEs are associated with malignant disease. And 1-year incidence of cancer diagnosis following an unprovoked event, even in the absence of excuse me, even in the absence of an identifiable risk factor for VTE is about 5 to 10%. So it has a diagnostic role in VTE, prognostic marker, because of its association with advanced tumor stage, higher tumor burden, increased risk of recurrence and metastasis, and shorter overall survival. Again, used for risk stratification at high risk, monitoring role, has again some research and experimental role. So, evidence-backed associations of D-dimer in cancer. What are the common malignancies where you would find association of D-dimer with increased levels of D-dimer? The most common malignancy associated is the pancreatic cancer, followed by stomach cancer. And of course, this is in this sequence. So, pancreatic cancer, lung cancer, GI cancer, ovarian malignancies, and you have your hematological malignancies. So, very high D-dimer levels are common in cases of pancreatic cancers, and this is risk associated with very high risk of VTE. Elevated D-dimer levels in lung cancer they signify the advanced stage, presence of metastasis and shorter overall survival, particularly useful in non-small cell lung carcinoma. GI disease stage and post-operative recurrence risk, ovarian cancer, again tumor aggressiveness and treatment resistance, hematological malignancies, risk of hypercoagulability and DICs. So what are the different ways by which we can identify the assays which are available in the market? So we have something called a whole blood agglutination assays, we have ELISA or alpha, and we have latest agglutination assays. Now whole blood agglutination assays specifically uses a bispecific antibody. One of it is directed towards an epitope on the RBC and the other one towards the D-dimer. So in presence of agglutination, this gets measured as turbidity. Very similar to this, we have latest agglutination wherein we have these beads which are coated again with antibodies, and again in presence of agglutination there is turbidity which gets measured. You have ELISA and alpha wherein the plate is coated by a capture antibody, and you have something called a tag antibody which is again which has these colors, and these colors reflect actually the presence of D dimer. Okay, so the D dimer assays are not the same. They may use different calibrators, different reagents, different methodologies, different antibodies, and this is an aspect which is significantly under-recognized by laboratories, testing and reporting, as well as the clinicians who are requesting these reports. In one report, there are over 30 different D dimer assays which are identified commercially as on week, and which uses 20 different types of antibodies. So D dimer is measured by immunoassays, but results varying depending on different assay calibration and reporting units. So two different approaches are there. You either report it in DDU or you either report it in FEU, but different labs, different units. Nanograms per ml DDU, micrograms per ml DDU, nanograms per ml FEU, again micrograms per ml FEU. And the patient goes to different labs, he will get himself tested, and he comes back to you with all sorts of results, all sorts of cutoffs. None of that is validated, most of it rather. Just to put things in perspective, the most common used unit by labs is nanograms per ml FEU, which is fibrinogen equivalent units, which has a cutoff of less than 500. Just 2 minutes, I'll rush through this. Okay. So, for all practical purpose, 1 DDU is equal to 2 FEUs. Okay. And what is the D dimer assay? As told by me, so this is based on CSI guidelines, something which has high sensitivity, it should be good enough to have the cutoffs, and it should have a very, very high negative productivity. But again, no assays is prone to limitation, and so is D dimer. Overuse and misinterpretation. Ever since COVID, this is one of the most overused, or rather, if I may say, misused tests, overly prescribed tests. And so again, different sorts of prescription, and again, so different kinds of interpretation. Heterogeneous sensitivity and specificity. ELISA has a different sensitivity. Latex has different sensitivity. In latex, you can have inter-observed variability, you can have interferences, like rheumatoid factors, and so on and so forth. So different thresholds for different assays, different FTPs used, so of course different cutoffs. And diagnostic cutoffs depend on age of the patients, as we just saw, that in patients above 50 years of age, the baseline of for D dimer increased. Clinical concerns, very, very important, because a good PTP is a mandate for us to evaluate a case of VT in lab. So clinical implications, again, diagnostic cutoffs, age-adjusted cutoffs, inter-lab variability because of the reasons which we just spoke. Okay. So D dimer assays are inherently heterogeneous. D dimer assays are not standardized or harmonized, and not all D dimer assays are validated for exclusion of VT. And the reason is because the British Committee of Standards in hematology recommends that you can only validate a test once you have 200 data points. Now that's practically impossible for any lab to do that. So that's the best case scenario. You should use the manufacturer's cutoff whenever possible. Again, one of the efforts has been put to, can we probably standardize or harmonize a D dimer assay. Now standardization means creating one single uniform rule or process for everyone. Now harmonization means aligning different rules or processes to work together, so that the variations can be reduced. So adoption of purified D dimer material up until now as a universal standard has not been easy. There have been some efforts on preparation of international references from pools of clinical samples, but basis this, harmonization rather than standardization is what has been recommended. Harmonization is the conversion of D dimer values from different assays to a common scale by a conversion factor, and use of different monoclonal antibodies of the same in the many different kits, and the heterogeneity of D dimer fragments in plasma would still make it harder to achieve higher tests. This is a challenge for each one of us, for all the labs which are practicing and subscribing to this test. So you have the good, and you have the bad, and you have the ugly, and of course this is significantly used in the diagnosis of VTE. The challenge is that there's no harmonization, the multiple reporting units, and the ugly part of it is that yes, there are no good amount of data which is present when these values are interchangeably used. So my key takeaways would be that it is useful in patients only and only if with a good clinical assessment, that is low or medium PTPs, and this again a positive case would require an imaging, but it will significantly bring down the incidences of unnecessary imaging and significant cost saving. And always remember that age adjusted cutoffs are extremely significant whenever you are dealing. To wind this up, thank you so very much. I'll be happy to have any questions if you have.
Do you see this D-dimer being utilized in the hospitals? I mean, as you have seen, it is not specific. Okay. It is not going to tell about anything about whether it is because of cancer, whether it is because of pregnancy. Pregnancy also it is going.
Yes.
Yes. So, and it is how do you try to how do you
Couple of things I'll give you. I'll give you a couple of things. So of course, the context, as you said, is very important. You have to understand your patient before prescribing for this test. There should not be any mindless prescription. So of course, the context is one aspect of it. Secondarily, the baseline becomes very important because baseline also varies. And most importantly, if it is the same D-dimer test which you are using, it could be from X, Y, Z, A, B, C, any instrument, any platform. Right now, there are 30 different types of commercial assays which are present. I am not advocating A is better than B or B is better than C. But if you are monitoring, at least the technical nuances must be understood. The same test needs to be used at least for serial monitoring. Like DICK patients, if you want to monitor, over a period of say couple of days, please stick to the same test. I believe that in the same hospital you'll have a possibility. But the problem is with all these standalone labs, like just mushroom, and there is random D-dimer tests being done without any clinical context, without any baseline, without any understanding of the patient. So that is what is significant. And once you start using them, and then you will be able to beat in cancer, beat in VT, beat in sepsis.
Are you saying that it should be basically used for prognosis purpose?
No,
not for diagnostic.
So diagnosis, I told you. So for VT, only and only in cases of low test probability, okay, low PTPs and medium PTPs only you can use it. Okay, if it is high, you are.
But that is not again going to exclude anything.
So it has high NP. No. So you can safely exclude. It has 99% NP.
Can you take the chance of 1% for thrombosis?
Low PTP I'm talking about. If it's a high PTP, if there is, you please go ahead and do an investigation. If D-dimer is elevated, you still will have to go and do an investigation.
That is what.
But low PTP,
negative also, then we also will have to.
No, the recommendations clearly say that low PTPs and moderate PTPs you can safely rule out. I mean, this is the recommended, the guidelines.
Serial measurements.
Yes, absolutely. So as far as the guidelines goes, it has a very good. I mean, that's the beauty of this test. It's a very high NPV, very good sensitivity. Yes, specificity is not as good as what you would like. Dr. Abhishant, thank you.
reduce errors, and how can we free up the time for the technologists in the lab.